Hello. Hmm. Pindah Eko.
Welcome to the limited edition Macau, a world reimagined just for you.
Said I'm all about it. Yeah, I'm all about it. Said I'm all about it. Yeah, 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 yeah. Said I'm all about it. Yeah, I'm all about it. Said I'm all about it. Yeah, 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 yeah. Oh, wound up, step out of the way. Louder, get better with age. I'm rowdy, I'm grounded, and I get my way. Ooh, let me see you move your body, see you shake it, make 'em turn it up and drag. Good, 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 good. I'm all about it.
Don't miss this moment. Discover limited edition Macau now. Create memories that will last a lifetime.
Hello, Peachy. Thank you.
Yes, can you hear me?
Yes, well.
All right. So a very warm welcome to each and every one of you from Asia and to all our audience worldwide. This is CPD Asia, the online continuing professional development platform for Asian Radiologic Technology Societies. And hosting the 60th CPD Asia is the Macau Radiological Technologists Association, MRTA. I am Peachy Luna, your CPD Asia program host. And to everyone, we are live streaming on YouTube. Please search PARI and VART channels so you can join us live or watch a replay. This CPD Asia is highly supported and graced by member societies, the presidents, all the officers and their representatives. Let us greet and welcome President of Perhimpunan Radiographer Indonesia, Indonesian Society of Radiographers, PARI, Dr. Gek Sugianto. We also have the President of Vietnam Association of Radiologic Technologists, VART, President Thai Van Loc.
Hello, everybody. Congratulations, MRTA. Thank you, Vichy. Thank you.
Thank you, President Loc. Attending for Hong Kong Radiographers Association is the Vice President, Mr. Wan Shun Boon Nelson.
Hello, everyone. Good evening. Nice to meet you again.
Yes, so I don't know if President Chun Yuan-Tu is here from Taiwan Association of Medical Radiation Technologists. But we have here President of Malaysian Society of Radiographers, President Mr. Sawal Marsaid.
Good evening.
Good evening, dear sir. We have President Vitarana Gamejri Malasen of Society of Radiological Technologists.
Hello.
Sri Lanka.
Congratulations, MRTA. Best wishes. Thank you.
We have received greetings from President Denise Chung of Singapore Society of Radiographers, or SSR, from Indian Society of Radiographers and Technologists, ISRT, President Mr. Mohan Lal Bhagwat, from Taiwan Society of Radiological Technologists, President Kuei Yuan Wu, and also from President of Japan Association of Radiologic Technologists, JRT, Mr. Katsuhito Oheda, and also from Cambodian Radiological Technologists Association, President Sophie Lee, from Palestinian Association of Medical Radiation Technologists, PAMRT, President Muhammad Abdul Ghani, and President of the Philippine Association of Radiologic Technologists, Incorporated, President Ruben Lorenzo. With us tonight is also our invited panelists from Macau, Ma'am Coronel.
Hello, nice to meet you.
Madam Chan Lai Kwan from Malaysia.
Hello. Nice to meet everybody.
Mr. Putu Adi Susanto from Indonesia. Oh. Miss Alice Chang from Taiwan.
Hello. I'm driving. Sorry, I cannot turn on the camera.
No problem, Miss from Vietnam, Sir Lu Trido.
Hello, everyone. Very nice to meet you again.
So our dear presidents and our invited panelists will be joining us again later for the Q&A session. Meanwhile, may I request everyone to please open your camera for a very short photo session. Thank you very much. So now it is my privilege to invite the president of Macau Radiological Technologists Association, Mr. Fernando Koch, to deliver his greetings.
Hello,
President
good evening, everyone. Today's CPD is 60 times, so far 5 years. Thank you for being here. Today, our focus is topics is about the stroke. It's a condition that is widely discussed, yet the science, image strategies, and clinical pathways behind it continue to evolve at a rapid pace. As a radiology technologist, we stand at the very front of the diagnostic process, whether it's the CT, MRI, or good stroke imaging protocols. The speed and accuracy of our work directly influence the treatment decisions and the patient outcomes. Even though the stroke is a familiar word, the latest guidelines, imaging updates, and workflow improvement deserve our close attention. Our goal today is simple: to refresh our understanding, highlight the key updates, and strengthen our confidence in the critical role we play in the stroke pathway. Every scan we perform, every decision we make can help secure procedure times, and sometimes that time is a life change. Thank you.
Thank you, President Pop, and thank you for your warm welcome and very inspiring words. At this point, I am pleased to introduce our moderator for this session. He is Mr. Chi Yong Huang, the Director of Academic Affairs of Macau Radiologic Technologies Association. So I now hand over the session to Mr. Huang. Mr. Huang?
Hey, thank you, Pichinuna and Fernando Korean Key. And now we begin the speech section. Just a quick note, since some country and regions require live quick questions for certification, we have added 2 questions to this CPD section. We will pop up after each topic, and you will have 1 minute to each. It's just for testing, so no pressure to answer. Thank you. And now, the first speaker is Ni Kai Hong Jerry. He is the chairman of the MRTA, and his topic today is the role of radio technologists in technician in stroke management in Macau. Let's welcome Jerry to start his speech.
Hello, everyone. My name is Jerry, and I am the chairman of the Macau Radiological Technologists Association. It is my great pleasure to present at the 60th Asia CPD platform. Today, I will be sharing a topic entitled The Role of Radiological Technologists in Stroke Management in Macau. In this presentation, we will explore how imaging drives stroke care, why timing is critical, and how radiological technologists contribute to patient outcomes from the moment a stroke patient arrives. I will also share a brief real case example to illustrate our role in acute stroke management. What is stroke? Stroke refers to a sudden loss of brain function. This occurs when a blood vessel supplying the brain becomes blocked or ruptures. Because the brain cannot store oxygen, any interruption leads to rapid cell death. For this reason, stroke is a time-critical emergency that requires immediate imaging. There are 2 main types of stroke. Ischemic stroke accounts for about 85% of cases and is caused by a blocked blood vessel. Hemorrhagic stroke occurs when a vessel ruptures and causes bleeding. As ischemic stroke is far more common and highly dependent on rapid imaging for treatment decisions, it will be the main focus of today's session. Macau's population continues to grow each year, and with this growth, we are seeing a predictable increase in stroke cases. Stroke is already one of the leading causes of long-term disability, and the demand for fast, high-quality imaging is increasing. For radiology departments, this means we must be ready for more frequent stroke code activations. During an ischemic stroke, millions of neurons are lost every minute. This is why we often say, time is brain. The faster we can complete imaging, the better the patient outcome. In Macau, stroke systems aim for a door-to-CT time of less than 20 minutes. Why do technologies matter in stroke care? Radiological technologies are often the first imaging responders when a stroke patient arrives. We control how quickly the scan starts and ensure that image quality is high enough to support accurate diagnosis and treatment decisions. Now let's look at the core concepts. In an ischemic stroke, the affected brain tissue can be divided into 2 main zones. The core is the area where brain cells have already died. Surrounding this is the penumbra, where the tissue is still alive but at risk. The goal of treatment is to save as much of the penumbra as possible, and imaging helps doctors to determine how much brain tissue can still be saved. That's why we always say, time is brain. The faster imaging is performed, the faster the doctors can decide whether the patient is suitable for intravenous thrombolysis or mechanical thrombectomy. And now, with the use of CT perfusion, the treatment window for thrombectomy can be extended up to 24 hours in some patients, making advanced imaging more important in stroke care. Macau's stroke pathway begins when the patient arrives at the hospital. emergency department teams use FAST method to identify possible stroke cases. Once a stroke code is activated, and radiology becomes the next critical step. Our responsibility is to ensure that CT, CTA, and/or CTP, MRI are ready without delay. Therefore, communication with emergency department doctor, neurologist, and the interventional doctor is essential to maintain a smooth and fast workflow. Non-contrast CT is the first imaging step in every suspected stroke case. Its main purpose is to rule out hemorrhage. For radiological technologists, the key priorities are speed and accuracy. Patient positioning must be fast and correct, and motion should be minimized, especially in elderly or confused patients. Thin slice reconstructions are essential to support accurate interpretation. Artifact recognition is also important. Dental artifacts and motion artifacts can sometimes mimic pathology. Finally, images must be transferred to PACS immediately. Even a 1-minute delay can significantly affect the doctor's treatment decision. Now move on to CT angiography, CTA. CTA is the key imaging tool for identifying large vessel occlusion, which determines whether the patient is eligible for thrombectomy. Radiological technologists must ensure high-quality IV access, typically 18 to 20 gauge needle, in order to support high-flow contrast injection. Bolus tracking must be set correctly to capture peak arterial enhancement, and coverage must extend from the aortic arch to the vertex to avoid any missing lesions. CT perfusion. CT perfusion measures blood flow and helps distinguish between the core and the penumbra. CT perfusion also provides quantitative information about infarct core and penumbra, guiding late window thrombectomy decisions. Radiological technologists must select the correct protocol, ensure full brain coverage, and minimize motion. Post-processing must begin immediately and send for reporting. This is our CT perfusion scanning page. As you can see, the total scan time is 77 seconds, with full coverage of the entire brain. Because the scan time is relatively long, minimizing patient motion is very important. In certain situations, head stabilizing straps or mild sedation by the doctor may be needed to ensure good image quality. MRI. MRI has very high sensitivity and is particularly useful for detecting acute ischemic stroke. Among all MRI sequences, diffusion-weighted imaging, or DWI, is the most sensitive. It can detect ischemic changes within minutes after stroke onset, and areas of restricted diffusion appear as bright signals. FLAIR imaging provides additional information by helping estimate the age of the stroke. In very early stroke, usually within the first 4.5 hours, FLAIR image may still appear normal. When DWI is positive but FLAIR is negative, this pattern is known as a DWI FLAIR mismatch. This suggests that the stroke is likely recent and may still be within the early treatment window. However, despite its advantages, MRI is usually not the first imaging choice in acute stroke. This is because MRI requires a longer scan time, and the patient must be stable and able to cooperate. For radiological technologists, understanding these MRI findings helps us appreciate how imaging supports clinical decision-making. Intravenous thrombolysis IVT. This shows how imaging drives decisions for IVT. Non-contrast CT plays a key role as the gatekeeper. Its main purpose is to exclude intracranial hemorrhage, allowing clinicians to safely consider thrombolysis. In selected cases, MR may also support decision-making. When we see a DWI FLAIR mismatch, it suggests that the stroke onset is likely within the early treatment window. The overall goal is to achieve an onset to needle time of less than 4.5 hours. For radiological technologists, speed is critical. Faster imaging directly leads to faster needle time. Clear and timely communication with the emergency department and neurology team is essential to ensure that treatment decisions are made without delay. This highlights the role of radiological technologists before and during mechanical thrombectomy, also known as endovascular thrombectomy (EVT). Mechanical thrombectomy has become a key treatment for patients with large vessel occlusion (LVO). It is used both within the standard time-based window of up to 6 hours and in selected patients within an extended window of up to 24 hours when CT perfusion shows a tissue mismatch. For technologists, our responsibilities include completing CTA and CTP as quickly as possible, communicating critical findings immediately, preparing angiography suite, and assisting with patient transfer from the CT room to the interventional room. During the procedure, technologists support the angiography workflow by ensuring radiation safety, managing contrast use, and confirming that all equipment is ready and functioning properly. Efficient coordination at this stage helps reduce delays and directly supports successful thrombectomy outcomes. This introduces the penumbra system, which is commonly used for mechanical thrombectomy in Macau. The penumbra system is a fully integrated, aspiration-based system designed specifically for the treatment of acute ischemic stroke caused by large vessel occlusion. It works by delivering a strong and continuous vacuum, allowing the clot to be aspirated directly from the blocked vessel. This helps restore blood flow to the affected area of the brain as quickly as possible. For technologists, our role includes preparing the aspiration system, checking all connections, and ensuring that the vacuum system is functioning properly before and during the procedure. How endovascular thrombectomy works in Macau. The first step of the procedure is to establish stable vascular access. A guiding catheter, such as an 0.088-inch system, is advanced into the target carotid artery. This provides a stable pathway for the devices used during thrombectomy. Throughout the procedure, a continuous saline flush is maintained. This is important to prevent clot formation within the catheter and to ensure smooth device movement. After the guiding catheter is established, a SL10 or XT27 microcatheter, together with a synchro microguide wire, is carefully advanced through the guiding catheter to cross the occlusion. This step requires precise control and smooth coordination to safely reach the blocked segment of the artery. Once the microcatheter and synchro guide wire have crossed the occlusion, they create a stable track for the reperfusion catheter to be advanced. The reperfusion catheter, such as the RED 72, is advanced over that microcatheter system. It's carefully positioned just proximal to the thrombus, meaning just before the clot. Once the RED 72 is in place, the guide wire and microcatheter are removed, leaving the RED 72 reperfusion catheter ready to perform clot aspiration. When the RED 72 reperfusion catheter is in place, it is connected to the penumbra engine. Aspiration is then activated to remove the clot from the blocked vessel. This step is known as debulking. If aspiration alone is not enough to fully clear the thrombus, a 3D revascularization device, such as the Solitaire, can be deployed through the same catheter to engage and retrieve the clot. Now let's watch an animation shows the left MCA stroke and how thrombectomy is being done by penumbra aspiration system. our stroke supply cabinet. In Macau, we'll restock the stroke cabinet right after we use it. This outlines the updated stroke protocol and pathway used in Macau Government Hospital as of 2026. For any suspected acute ischemic stroke, the first step is non-contrast CT and CTA. If hemorrhage is detected, the pathway stops and the patient is referred to neurosurgery. If a large vessel occlusion is found, the next step depends on the time since onset. If the patient is within 0 to 6 hours, mechanical thrombectomy can proceed without perfusion imaging. If the patient is between 6 and 24 hours, CT perfusion is required. If there's a mismatch ratio of 1.8 or more, the patient qualifies for thrombectomy. For IV thrombolysis, MRI may be used to assess onset time. A DWI flare mismatch suggests the stroke is likely within 4.5 hours, supporting intravenous thrombolysis treatment. This shows the door-to-needle performance at Macau Government Hospital from January to September 2025. During this period, we have consistently maintained a door-to-CT time of under 20 minutes. This reflects strong coordination between the emergency department, the neurologist in stroke team, and radiological technologists. Maintaining this target is critical because faster imaging leads to faster treatment decisions and better patient outcomes. So, why are we able to consistently maintain a door-to-CT time of under 20 minutes? First, our radiological technologists provide 24/7 coverage in the emergency department. This ensures that CT imaging is always available whenever a stroke patient arrives. Second, our hospital IT department has developed a one-click summoning system that greatly improves coordination. The first summon is activated when the radiological technologist receives the initial stroke alert. At this stage, we immediately prepare the CT scan room and make sure it is ready for the incoming patient. Once CTA confirms a large vessel occlusion and the neurologist decides to proceed with thrombectomy, the second summon is triggered. This second summon means the patient is going for IR thrombectomy. Radiological technologists then quickly prepare the interventional suite, switch on the angiography system, and set up the penumbra system before the interventional doctor, anesthetist, and nursing team arrive. As you can see, both summons directly involve radiological technologists. This clearly shows how critical our role is in managing acute stroke cases and maintaining fast, efficient treatment pathways. This slide shows the door-to-puncture performance at Macau Government Hospital from January to September 2025. During this period, we have successfully maintained the standard door-to-puncture time within 90 minutes. First of all, I'd like to thank our hospital IT department for the one-click summoning system, which plays a key role in early activation and coordination of the stroke workflow. Also luckily, Macau is geographically small, with a land area of approximately 32 square kilometers, which allows our stroke team members to return to the hospital within 30 minutes when they are on call. Here's a case sharing from Macau. A 72-year-old female patient with a history of hypertension and lipid disorder. She presented with right-sided weakness and severe neurological deficits, with an NIHSS score of 18. The stroke protocol was activated by the stroke team neurologist. CTA confirmed a left middle cerebral artery occlusion and MRI with a DWI flare mismatch. Then stroke for IR was activated by the stroke team neurologist, and the patient received intravenous thrombolysis followed by mechanical thrombectomy. First, a plain CT scan was performed, which showed no evidence of intracranial hemorrhage. and CTA of the head and neck showed an occlusion of the left middle cerebral artery. Plus MRI demonstrated a DWI flare mismatch, suggesting an early ischemic stroke. Angiography demonstrated a total occlusion of the left middle cerebral artery at the M1 segment. Mechanical thrombectomy was performed using the penumbra aspiration system, and complete recanalization was successfully achieved in a single pass. Following endovascular therapy, dual energy CT was performed. The iodine phase showed some contrast staining in the left basal ganglia within the MCA territory, while the water phase showed no evidence of acute hemorrhage. This indicates that the endovascular treatment was successfully performed without hemorrhagic complications. The patient was then transferred to the intensive care unit for further monitoring and observation. This shows the patient's full treatment timeline from arrival to reperfusion. In this case, the exact onset time was unclear, and the patient was found by family at 12. The patient arrived at the emergency room at 12:40. Triage was completed within 1 minute, and the stroke protocol was activated shortly after. CT and CTA were completed within 9 minutes of arrival, well within our door to CT target. MRI was then requested by neurologists and performed, and a DWI flare mismatch was identified, suggesting the stroke was still within the 4.5-hour treatment window. Based on these findings, the neurologist made the decision to proceed with endovascular thrombectomy. IV thrombolysis was administered with a door-to-needle time of 55 minutes. The patient entered the interventional suite at 1:50, and arterial puncture was achieved at 2:09, resulting in a door-to-puncture time of 89 minutes. Final reperfusion was completed in under 2 hours from arrival. This case clearly demonstrates how efficient imaging, rapid communication, and strong multidisciplinary teamwork allow us to meet time targets and deliver timely stroke treatment. In summary, imaging is the foundation of stroke treatment, and radiological technologies determine both the speed and quality of that imaging. Our technical skills, communication, and professionalism directly influence patient outcomes. Stroke care is truly a team effort, and radiological technologies are a vital and indispensable part of that team. That concludes my presentation. Thank you very much for your attention.
Thank you, Jerry, again for his sharing. Just a quick note, since some countries and regions require live quick questions for certification, we have added 2 questions for this CPD section. They will pop up after each topic, and you'll have 1 minute for each just for testing, so no pressure to answer. Thank you. The second speaker is MRTA Macau. He is the Vice Chairman of the MRTA, and his topic today is the application of CT and MRI in stroke management. Let's welcome Macau to start his speech.
Hello everyone, my name is Marco. I'm the first Vice Chairman of MRTA. Thank you for being here. Today I will be presenting on the application of CT and MRI in stroke management. We will focus on three main aspects: basic principles, imaging protocols, and practical operations in the acute stroke setting. In acute stroke, imaging serves four critical goals. First, we need to rule out hemorrhage, because if there is bleeding, we cannot give thrombolysis. Second, we must identify the ischemic coil. There is the irreversible damaged brain tissue that is already dead. Third, we assess the penumbra, which is the salvageable tissue surrounding the core. And fourth, we perform vascular assessment to detect large vessel occlusions, or LVO, and to evaluate collateral circulation. Here is the outline for today. We will first cover CT imaging, including NCCT, CTA, and CTP. Then we will move to MRI, focusing on DWI and FLAIR. Finally, I will walk you through our protocol based on syndrome onset time with two clinical cases. CT uses X-ray beams rotating around the head to measure tissue attenuation, which is expressed in Hounsfield units. It is fast, widely available, and remains the first-line imaging modality in the emergency setting. Blood appears hyperdense. Brain parenchyma is isodense, and water is hypodense. The difference is essential for detecting early ischemic change or hemorrhage. NCCT is the cornerstone for stroke imaging. It is performed from the skull base to the vertex with 5 mm slide thickness. Our primary goal is to exclude intracranial hemorrhage, but we also look for early ischemic signs. These include the hyperdense MCA sign, which indicates thrombus in the middle cerebral artery. We also look for loss of gray-white matter differentiation, especially in the insular cortex. And we check for the circular defacement due to brain swelling. Now let's move to CTA. We perform a two-phase acquisition. The arterial phase covers from the aortic arch to the vertex using bolus tracking. This identifies the exact site of occlusion. Then we have a 16-second delayed phase. Importantly, this phase has a reduced scan range from the skull base to the vertex to minimize radiation while focusing on intracranial collaterals. This delay allows us to evaluate collateral circulation, which is a key predictor of outcome and may extend the therapeutic window. Now let's talk about CTP, which we use for patients presenting between 6 to 24 hours. On our GE CT system, we use a whole brain perfusion protocol with 120 to 160 millimeters of coverage. The acquisition parameters are as follows. Tube voltage is 80 kV and tube current is 200 mA. Rotation time is 0.35 seconds. Slide thickness is 5 millimeters. We use a two-phase protocol. Phase 1 starts with a 7-second delay, followed by 18 passes with a 2-second interval. Phase 2 begins 5 seconds after Phase 1, with 7 passes and a 5-second interval. The total scan time is 76.7 seconds. The effective dose is about 3 millisieverts. Now for the post-processing. GE software automatically calculates key perfusion parameters. We define the ischemic core as area with cerebral blood flow, or CBF, less than 15% of normal. The palumba, which is suffragable tissue, is defined by Tmax greater than 7 seconds. The software then calculates a mismatch ratio, which is the palumba volume divided by the core volume. In clinical practice, a mismatch ratio greater than 2 supports patient selection for phlebotomy in the late window, even beyond 6 hours. Now let's move to MRI. MRI uses magnetic fields and radio frequency pulses to image hydrogen protons. Its major advantage is superior soft tissue contrast and extreme sensitivity to acute ischemia. However, it takes longer and has contraindications like metallic implants or claustrophobia. Despite this limitation, MRI is invaluable for specific scenarios, particularly wake-up stroke. In wake-up stroke, we do not know the exact onset time. We use a focused MRI protocol, diffusion-weighted imaging, and T2 flare. DWI detects cytotoxic edema and becomes positive within minutes after stroke onset. Flare suppresses cerebrospinal fluid and shows vasogenic edema, which typically appears hours after onset. When DWI is positive but flare is negative, we call this a mismatch. It suggests that onset occurred within the last 4.5 hours, so the patient may still qualify for thrombolysis. If both are positive, the stroke is likely older and thrombolysis is not indicated. You might wonder why we do not perform a full MRI protocol for these patients. The answer is simple. In the emergency setting, time is critical. DWI plus flare takes only 3 to 4 minutes, compared to 10 to 15 minutes for a full study. Vascular information has already been provided by CTA, so we do not need MRA. This focused approach gives us just enough information to make the treatment decision quickly and safely. Let me summarize our stroke protocol. For patients within 0 to 6 hours, we perform NCCT and CTA with the 16-second delay. If large vessel occlusion is present, we proceed it directly to thrombectomy. For patients in the 6 to 24-hour window, we add CTP to assess core palumbar mismatch. For wake-up stroke or unknown onset, we start with NCCT and CTA Then add MRI with DWI and flare to determine the DWI flare mismatch status. This algorithm ensures we use the right imaging for the right patient at the right time. Let's look at our first case. A 55-year-old male presented with left side hemiplegia for 14 hours. He was awoke and reported that symptoms began around midnight. NCCT was negative for hemorrhage. CTA arterial phase showed complete right internal carotid artery occlusion. But on the 16-second delay phase, we could see the collateral flow reaching the right cerebral hemisphere. CTP revealed a very large penumbra with a mismatch ratio exceeding 180. Based on this favorable profile, we proceeded with thrombectomy and the patient had a good recovery. This case demonstrates that even in the late window, CPP with an extremely favorable mismatch ratio can justify thrombectomy. Our second case is a 78-year-old female who woke up with aphasia. She was fully awake with normal limb strain. Last known well was 10 hours prior. NCCT was negative, and CTA showed no large vessel occlusion. We then performed a focused MRI. DWI was positive, but flare was negative, a classic DWI flare mismatch. This indicated that despite the unknown onset time, her stroke was likely within the 4.5-hour window. She received thrombolysis and showed improvement. This case highlights the power of DWI flare mismatch in guiding treatment for wake-up stroke patients. Let me summarize the key points. First, NCCT is essential for ruling out hemorrhage and identifying early ischemic signs. Second, two-phase CTA, especially the 16-second delay, provides a critical information about collaterals. Third, CTP with GE software thresholds, CBF less than 15%, Tmax greater than 7 seconds, and a mismatch ratio greater than 2, is the gatekeeper for late window thrombectomy. And fourth, for wake-up stroke, the DWI flare mismatch on MRI help us determine thrombolysis eligibility. Here are the key references that support our imaging protocols and clinical decision making. Thank you very much for your attention.
Thank you, Marco, for the great presentation. And now here is the Q&A section. Unfortunately, we are running a little bit tight on time, so we can only have the time for one question for each speaker. There is a question from the audience who asks, what is the main system level challenge of radiological technologists in Macau face when support acute stroke management. This is the question for Jerry.
Hello,
Jerry,
can you hear me?
there with me?
Yes.
Yes.
The main challenge in Macau, yes? Yes. The main challenge in Macau, I think, is the limit CT and MRI capacity during our peak office hours. Because we work in the government hospital, and we always experience high imaging workloads, especially inside our emergency department. So when our CT scanners sometimes are occupied with some cases like trauma, ICU, or some inpatient cases, so the stroke imaging cases may face delay. So this will put the pressure on us. Our technologists need to think carefully to triage these cases quickly to see which one is get the priority to scan first. So usually stroke cases we will perform first. I think this answers your question.
Okay. Thank you, Jerry. And the next question is for Marco. Here is another question from audience who asks if a patient has motion artifact during the CT perfusion scan, how should it be resolved?
Okay. Good evening, everyone. This is a good question, and normally, if the patient is unconscious, maybe he or she just a little bit motion. So normally, both the most famous AI rapid software or GE, our system in the GE system in our department also have the motion correction for the small motion. But if the patient is really maybe sit up or anything, it may need to ask the emergency doctor to give him some medicine to stabilize first. Yeah.
Okay. Thank you, Marco. That is the end of the Q&A. If you have any further questions, feel free to reach out the speaker's email address. And finally, thank you for your attention. Now, let's hand over to Pichinuna for the introduction of next Asia CPD section.
All right, so, ladies and gentlemen, now as we come to the conclusion of this evening's CPD Asia session, I would like first to extend our heartfelt thanks to our distinguished speakers, Mr. Lei Kai-hong Jerry and Mr. Lam Yo-pong Marco for their insightful presentations, and to our moderator, Mr. Chi Leung Hong, for guiding the discussion so effectively. Before we close, I warmly invite everyone to join us in the next CPD Asia program and to give us an invitation and tell us more about this exciting event. Let us welcome President Veterana Damej Wimala Sena of Society of Radiological Technologists, Sri Lanka.
Hello, hope you can hear me.
Yes, Bob.
Okay, so thank you very much, PG. So I invite all of you for the next CPD, which is hosted by ourselves, the Society of Radiological Technology Sri Lanka. We have organized two presentations, one on the research of research activities of the radiographers, and the other one on the green radiotherapy that is by one radiotherapy lecturer in one of our universities. So both of these presenters are from the university staff. They are one on the diagnostic side and other one on the therapy side. So I hope it will give you some much more information about the radiography. So thank you very much. See you next time. See you on 26th April Thank you.
Thank you, President Vitarana Gamej Vimalasena. We will definitely save that date. So as I end, we would like to express our sincere gratitude to MRTA for your unwavering dedication, advancing our profession, for your continued support to CPD Asia program, and for graciously hosting a successful 68th CPD Asia. We also extend our heartfelt thanks to VT Healthcare Vietnam and all our Zoom sponsors for their generous support. We also deeply appreciate the ongoing cooperation of our CPD Asia IT team and the unwavering support of all our presidents, the officers who work tirelessly to bring you a meaningful CPD Asia sessions every month. And above all, we offer our warmest thanks to all our registered participants and our live audience on YouTube. Your presence and enthusiasm have truly made the CPD Asia program a success. Again, I warmly invite you to join us again for the next CPD Asia session next month. I'm Peachy Luna, your host, saying thank you, everyone. Congratulations, MRTA. We'll see you next time.
Thank you. Thank you all.
Thank you. Thank you.
Thank you.
Congratulations,
See you.
President Kok.
Thank
Thank you.
you.
Thank you.
Bye bye. Good night.
Bye. Bye. Bye.
Thank you.
Bye bye.
Bye.
Thank you. So nice session. Interesting one.
Oh, Sir Selva Kumar.
Thank you. Namaste ji.
Thank you for
Namaste.
joining us.
Thank you,
Just I am
Peachy,
doing
and
with some
thank you, IT
patient procedure.
department.
That's why I am not able to come. Thank you.
President Mohan, ISRT, thank you for joining us tonight.
Have a wonderful webinar, and thanks to the IT team. Those help because I was unable to connect, but they helped timely.
Wow.
Thank you. Thank you very much to IT department also.
Thank you, CPD Asia IT team.
Recording.